welcome everybody to this session. So our session today is called Exploring the Experiences of LGBTQ plus people living with dementia. And our presenter today is John Hammond from Brighton and Sussex Medical School. And just a few words about John before we start. So John is a former carer for a parent who lived with Alzheimer's disease. He's worked as both head of service and acting CEO at Brighton and Hove LGBTQ Switchboard, leading an award-winning project that provides peer support opportunities for LGBTQ plus people living with dementia. He's a core member of the LGBTQ plus Dementia Advisory Group Community Interest Company, and he's been a public theme advisor in dementia studies at Sussex Partnership NHS Foundation Trust, and also at the National Institute of Health and Care Research, also known as the NIHR. So John has worked on several co-production projects, including raising awareness of quality of life priorities for people living with HIV and cognitive challenges, and resources to support LGBTQ plus and inclusive practices in residential settings. John's currently undertaking a funded PhD at BSMS to explore the experience of LGBTQ plus people living with dementia. So it's really great to have John here. So without any further ado, I'd like to hand over to John, who's going to introduce himself and then talk about exploring the experiences of LGBTQ plus people living with dementia. So thanks again, John.
Thank you, Jeremy. That's brilliant. I'm just going to share my slides. Okay, well, what a pleasure to be here. I'm John Hammond. I use pronouns he, him. The kind of overarching nature, I think, of these webinars is this idea of dementia in a diverse world. And I'll be specifically talking about the experiences of LGBTQ people living with dementia. So we are together on our yellow brick road until 2 o'clock. And I'll talk for around about 40 minutes, hopefully maybe a little bit less, because you might get bored of hearing my voice, but it will give us plenty of time, hopefully, for some questions as well towards the end. So our time together, I'll split it into 5 parts. So part 1, I'll talk a little bit about me. I was asked to kind of give an idea of my biography, I guess, and how it kind of contextualize my journey in my kind of research career as well. So part 1 is called "It Hasn't Always Been Rainbows and Giggles," which is a saying I pinched from one of my service users when I worked at Switchboard. In part 2, we'll look at this interaction of dementia and LGBTQ plus lives, so the lives of lesbian, gay, bisexual, trans, and queer and other minoritized sexual and gender identity lives. And we'll look at what the literature tells us, and that will kind of set us up nicely into the next 3 parts of my talk, which are about some projects I've been involved in. So in part 3, I'll be talking about a project which is a large-scale project called Determined. And when we get there, I'll tell you more, but it's called "It's Important That You're Here and We're Being Recognised" in part 3. In part 4, the Circle Project. So the Circle Project stands for Creating Inclusive Residential Care for LGBTQ plus elders. So a beautiful acronym, I guess, for what is undoubtedly a kind of complex project that looked at LGBTQ inclusion, specifically within residential care. And in the final part, part 5, I will talk a little bit about my current PhD research. So I'm a 2nd year PhD student at Brighton Sussex Medical School, as Jeremy said, and I have my project is called Show and Tell. It's a photography-based project, and I'll tell you more about that. And then a couple of kind of slides just on some useful resources that might be helpful to take away from today, and some time for some questions too. So let's go into part 1. It hasn't always been rainbows and giggles. So 1972 was an important year. So this is me. Oh, look, cute. So I was born in 1972, just 5 years after the partial decriminalisation of homosexuality. The Sexual Offences Act in 1967 legalised homosexual acts in England and Wales, provided that they were consensual, in private, and between two men who are at least 21 years old. And the Act did not specifically address sex between women. In 1972 as well, the first Gay Pride March took place in London, organised by the Gay Liberation Front and the Campaign for Homosexual Equality. Less than 1,000 people took part. It was a very small scale. And as you can imagine, with just 5 years after the Sexual Offences Act, it was a very risque, very daring thing to do in public. The demand was for liberation, to change society and not conform to it. The radical vision of the organisers with a new sexual democracy without homophobia and misogyny. Erotic shame and guilt would be banished together with compulsory monogamy, gender roles, and the nuclear family. There would be sexual freedom and human rights for everyone. The message was innovate, don't assimilate. Okay, so in my teenage years, in the 80s, there was a heightened media messaging around HIV and AIDS. AIDS was originally called Gay-Related Immune Deficiency, GRID, and was labelled in some of the media throughout the 80s as the gay plague. As a teenager, I was terrified that any sexual conduct whatsoever with another man would mean an inevitable death of AIDS-related illness. In 1988, so just as I was about to leave school, secondary school, the Section 28 of the Local Government Act came into force, and it prevented the promotion of homosexuality as a, inverted commas, pretended family relationship. It forbade teachers from informing children about LGBT people and same-sex relationships, which of course led to discrimination and prejudice of LGBTQ plus people. And the Act was only repealed in 2003. So in 1988, at the same time of this Local Government Act, Section 28, I told my mum that I was gay. And that didn't go down particularly well, unfortunately. And I left home, I left my family home soon after. My mum and I had a very difficult relationship throughout our lives, which was actually only really restored when she received her dementia diagnosis in 2015, so 10 years ago. I became her primary caregiver, as Jeremy said in my biography, until she died in 2018. And so dementia actually for us was a connective experience and changed the course of my life and has brought me, I guess, here today to talk to you. So just a tiny bit more on this timeline. I think it's important because all of these social and political events shape our lives. They inform our worldview and how we interact with the world around us. So the World Health Organization declassified homosexuality as a mental illness in 1992 and declassified trans identities as a mental illness in 2018. I've enjoyed the freedoms that people before me fought for. So in 2015, the Civil Partnership Act allowed same-sex couples to enjoy civil partnerships. And in 2006, the age of consent was lowered to 16. So these are kind of modern, very modern social and political events in our history. In 2010, the Equality Act came into being, which gave us protection amongst other protected characteristics alongside gender reassignment, gender and sexual orientation. And we currently live in, I guess, very uncertain times. So being very aware that as we enjoy liberty and as we enjoy freedom and legal protection, as social attitudes towards LGBTQ people change, in the run-up to one of the projects that I'll talk about later, which was conducted last summer, there was a lot of, all of the political parties in the run-up to the general election had an opinion about particularly trans lives, but more broadly LGBTQ plus lives. So we live in a time of uncertain political times, an awareness that rights are won and can also be taken away. So I guess from this brief and simplistic timeline, And we can see that LGBTQ plus lives have been both pathologized and criminalized. Social and political events, of course, inform and shape our worldview and our interactions with the world around us. And again, I enjoy the freedoms I have today and thank and give love to the people that have fought for those before me. So, okay, so of course, LGBTQ lives aren't lived as a single homogenous experience. It's essential to appreciate that not all LGBTQ plus people have the same life experiences. As with all people, sexual orientation and gender identity are only parts of the complexity of our identities. And this diagram depicts how some parts of who we are give us undoubted societal privilege and power, and other aspects of who we are marginalize us and put us at a risk of oppression. So I'm white, I'm male, I have a postgraduate education, I'm securely housed, I'm able-bodied, and I have a gender identity that aligns with the sex I was assigned at birth. So I have not, as a result of this, experienced transphobia, racism, ableism. My sexual orientation has exposed me to homophobia and violence. But I'm also very aware of the participants who I interact with in my research projects, obviously many of which are, in my field of work, are older people, are considered in some way less able or disabled. They may identify as trans people. They identify with a broader ethnicity than me, and so are exposed to various intersecting discriminations as part of just because of who they are in our society. So, okay, so final bit from who I am. So Jeremy, in my biography, mentioned that after 2015, I guess, once my mum received her dementia diagnosis, my life took a very different turn. And so I became a volunteer with Alzheimer's Society. So I volunteered with them for around 10 years. I worked in the community for a charity which is near to me in Brighton called Switchboard, which is a 50-year-old charity that's been supporting LGBTQ plus people for all of that time. And I particularly was passionate about the support for older LGBTQ plus people and those with chronic conditions such as dementia. I've worked as a public theme advisor with the National Institute of Health and Care Research, so contributing to them my experiences of being a caregiver, and was part of the formation of a community interest company, which is called the LGBTQ plus Dementia Advisory Group. And the group worked to advance, I guess, awareness and knowledge about this intersection of LGBTQ plus needs that may be specific to what it means to live as a LGBTQ plus person with dementia. And then all of this journey, all of that timeline of events of kind of informing my worldview and working in all of these different places in the community, etc., has brought me to this place of I'm a second-year PhD student now at Brighton and Sussex Medical School, as Jeremy said, and I'll talk a bit about my research as we move along our journey today. So part two, so just thinking about dementia and LGBTQ plus lives. I quite like this infographic from Professor Livingston and colleagues that came out in 2020. And I'm aware that a couple more risk factors for later life dementia have now been added. But I like this one because we know that from Professor Livingston's work that there are what's considered modifiable risk factors for later life dementia, some of which have more influence at a young age, some at middle age, some at later age. But some of these risk factors, such as smoking, excessive alcohol consumption, infrequent social contact, and depression or mental illness, are disproportionately seen within LGBTQ plus communities. So research will tell us that trans people, for example, are 4 times more likely to experience depression than non-trans people. The experience of mental illness is greater in lesbian, gay, and bisexual adults compared with heterosexual counterparts, as is alcohol and drug use. And we know that LGBTQ plus people are more likely to live alone, be single, and less likely to have children, and therefore, arguably, are more reliant or more likely to be reliant on formal care services. Okay, and so all of these risk factors, of course, interact. They don't sit alone. So if we are experiencing mental ill health, for example, we are likely to be less socially connected. We are likely to be more physically inactive, etc., etc. So just a kind of background, I guess, to appreciate that different communities may be, I guess, at risk of later life dementia in our society. And this slide, I guess it might be tricky to see on screen, but really, as far as dementia research, only since the 90s have we started to really think about how different parts of who we are, so our identities, our kind of social location, what the impact of that might be. And on this particular slide, it looks at barriers and facilitators to dementia diagnosis. So we can see this broad green is more general kind of research, and the colored, it might be tricky to see, but the different colors are things like familial position, age, ethnicity, gender, etc. And in this huge gap on the right of dark green, we are starting to close this gap and understand as well and add to our appreciation of who we are and how that interacts with our dementia. We are understanding more about things like sexual orientation, gender identity, and we can umbrella that, I guess, with LGBTQ plus identity. So we're appreciating more and more that who we are, how we've lived, will affect our kind of life with dementia. So what does the literature tell us? We understand that dementia may jeopardize feelings of autonomy. And so for LGBTQ plus people, that might affect how and under what circumstances and to who or to whom we disclose very important personal things about ourselves, such as our sexual and gender identities. Dementia is often characterized as with symptoms of memory loss or diminished decision-making capabilities, for example. And under those circumstances, estranged family members may re-enter the lives of LGBTQ plus people and make decisions about their health and care needs that are not affirmative of their identities or of their wishes for their future. Many LGBTQ plus people are very anxious about the future, I guess, and are not often interactions with health and care services that do not appreciate some of that history, some of that lived experience, some of what family might mean to LGBTQ plus people. And some of these concepts I'm going to touch in when I talk about the research projects I've been involved in a while. We know that LGBTQ plus, is not a homogenized experience, as I said, and so some people within the kind of LGBTQ initials are living and experiencing particular vulnerabilities when they are living with dementia. So trans people, for example, may be particularly vulnerable within care settings to comply with normative approaches to kind of cisgenderism or heterosexualism. And trans people also may experience discrimination in health and social care, where their identities or gender expressions of bodies are seen as non-normative. And so an undue, I guess, or unwanted level of examination about trans identity and who we are as trans people. And time and again, the research will tell us on a kind of positive side that families of choice, and I use this term because people use all kinds of synonyms such as rainbow family or families of choice, all kinds of different synonyms for this idea of people that are close within your inner circle. They may be parts of the family into which you were born, but they may also be this blended mix of those who share potentially LGBTQI plus identities and are exceptionally important because they play this protective role, against loneliness or loss of autonomy and agency, and are instrumental, I guess, in enhancing mental health and well-being. So what's needed? So we know where some of the gaps are and what the literature is telling us, what the evidence is telling us. We know that health and social care services, of course, play vital roles in supporting the independence and quality of life of people living with dementia and those who love and support them, their caregivers. We know that for some people, and that can include those with LGBTQ plus identities, barriers to services exist, and therefore some people may avoid seeking health and social care when arguably it may be of most need and of most benefit. And what we do know, I guess, is that the stories, the first-hand stories and the views of LGBTQ plus people living with dementia are mostly missing from the literature. And so there is still this huge need, I guess, to hear those stories firsthand. We need to understand what it means to live when we interact with our LGBTQ identity with chronic health conditions such as dementia. And that need remains. So this idea to hear those first-hand stories about how dementia services may or may not reach LGBTQ plus people, and explore the positives and the barriers that they experience. So, which leads me nicely to part 3. So it's important that you're here and we're being recognised. This is a study that I did that heard the voices of participants on a research study called Determined. So what did I do? Determined is a large-scale research project that's a huge collaboration between 7 universities. And Determined fundamentally seeks to understand what are the differences in dementia care and who gets worse or better care, what aspects of dementia care lead to good and bad quality of life outcomes, and how are outcomes for people with dementia affected by the cost of their care when they're diagnosed, and the amount of health and social care they get and the circumstances under which they get those. And Determined is a study that has recruited over 900 people living with dementia, and they are interviewed annually over at least 3 years. And currently the study is ongoing. What Determined has previously struggled with is recruiting people from LGBTQ plus communities into the study. And so for my research within the Determined cohort, I was able to interview and kind of hear the stories of everybody in the cohort, or in this 900 plus cohort of people who identified in some way within LGBTQ plus communities. That meant that for me, that was only lesbian, gay and bisexual. There were no trans people or broader gender diverse people recruited into Determined. I guess that's telling maybe of the barriers, I guess, that continue to exist, not only in health and social care, but in research more broadly, in recruiting of this broadest possible spectrum of LGBTQ plus people. So nonetheless, the literature is sparse. So there are very few studies that have reported on the first-hand experiences of LGBTQ plus people living with dementia. And so there was real value to this particular project. It, undoubtedly, although small scale, still of high value. So participants, there were 5. They had ages ranging from 53, so my age, up to 82, and were located in metropolitan areas of either Brighton or London. And after I'd interviewed them and heard about their experiences, I looked at the transcripts of the interviews and applied a novel approach to kind of analyze them through an approach called the candidacy framework. And the candidacy framework has 6 dimensions that relate to that can kind of relate to the stages of a dementia journey, all the way from pre-diagnosis, so this identification of symptoms, to the diagnosis process, and post-diagnosis and offers of support and the experiences of people after dementia diagnosis. So the candidacy framework has these themes identification, so how symptoms are identified, how people then use those identification of symptoms to navigate the health services, which can be very complex, can be less or more permeable in this sense to kind of access, get through all of the different barriers and challenges that people face. And onward, I guess, the candidacy framework thinks about the offers or non-offers that are given to people after a diagnosis of a health condition, and also the operating conditions under which health services are kind of operate, I guess, throughout all of the stages of this sort of journey from identification to offers of support post-diagnosis. And the candidacy framework has been used to explore experiences of various health conditions, and but has never been used to analyse the experiences of LGBTQ plus people living with dementia. So there's a novelty, I guess, to this particular project. And I'll give a few kind of snapshots of what people said in a moment, but the key findings were that participants did not routinely disclose their lesbian, gay or bisexual identities to dementia services professionals, despite feeling that was an essential aspect of who they are. So they chose when and under what circumstances to disclose. And so there's often a friction between both health and social care services wanting to find out as much as possible about an individual to provide what's often called the kind of person-centered, most holistic services to them. But participants in my findings didn't routinely disclose at the point of diagnosis. The gay male participants, the older gay male participants in my particular study relied on their resilience of overcoming previous experiences of lifetime discrimination to navigate complicated dementia care systems. And I have a nice kind of something from one of the transcripts here. So I think it depends also on your ability to stand your corner in things. I think if you're people in our age group, 80s, you see you've come through a period when, you know, men committed suicide and all that, being exposed as gay. But we've never been like that. And I always remember saying to myself before we met, I'm not going to be a second-class citizen. Bugger that. So this idea of sort of ego strength and people using those experiences of kind of lifetime discrimination. In this particular instance, the person, their GP had told them to go away and come back another day, flippantly, I guess, in some way. And they knew something was wrong, and they pushed and demanded kind of referral to secondary services, and that's when the dementia diagnosis was given. So in supporting much of previous, I guess, research with LGBTQ plus people, this idea of chosen family, family of choice, rainbow family, provided this important, essential support network outside of formal services. So these informal networks were essentially important. There's an absence rather of, and that continues, specific support services for LGBTQ plus people living with dementia, and people reported. Of course, there are some peer support spaces that people can go to, but they don't always feel like the right places for them. They don't kind of celebrate and support their kind of lived history. And so having the option, I guess, for other support services would be ideal. And very tellingly, I guess, for this interaction with social care services as well, all participants were very concerned about future care needs and how formal care services would respect and affirm their, in this case, lesbian, gay and bisexual identities. And so just a couple of quotes, I guess, to kind of reinforce some of the things that came out of the project. So when we say our family, they were talking about the gay community. Certainly our gay friends are our family as much as anybody. I mean, there isn't a description. They're more than friends. They're not your lovers, but they've been so brilliant, haven't they? Marvelous. I mean, we do have marvelous, marvelous friends and known them for many years. And people talked again about this idea of future support that they might need. So I think the more I need support, the more I want to know that I'm the more I want people to know that I'm gay. Apologies. but not necessarily sort of to chat about it. I don't want to hide it, but yeah, I will want to know when I start needing more care. So this idea of a kind of timing of disclosure of identity. So maybe not at the beginning of a dementia journey, so at the diagnosis stage maybe, but later on as people kind of start to imagine needing more and more formal care services, they felt like maybe that would be an important time to start to share additional parts of who they are, their LGBT identities. And one of the new situations we're encountering and having difficulty with, and I suspect it might be mirrored over the wider LGBTQ community, is actually looking for, so actively seeking LGBT friendly carers. Okay. So you can find out more about this study. It was published in the International Journal of Geriatric Psychiatry at the summer of last year. And you can go to the Determined website as well, determined.org.uk. And there's a video of me talking with the lead program manager for the Determined project in interview about this study. Okay, so we're moving on. So part 4, and I think this is particularly relevant, I guess, for social care, specifically residential care. So a project I was involved in over the last couple of years, which has come to an end now, is the Circle project. And the Circle project stands for Creating Inclusive Residential Care for LGBTQ plus elders. Circle had 3 elements to it. And so it had 5 care homes that went through a Pride in Care kind of accreditation scheme. And Pride in Care assesses LGBTQ inclusion more broadly in all aspects of the organisation. So so that would include everything from policies that are in place to marketing materials to the comms to the activities that occur within the care setting, for example, and supports those kind of settings and provides recommendations for kind of improved LGBTQ inclusion. Circle also had this a community of practice. It was an online quarterly meetings of people from all aspects of social care, really, but mostly people who worked in residential care settings. And the real intention, I guess, of the community of practice was to establish a safe space for everybody to kind of create shared learning around LGBTQ inclusion, and not to be afraid, I guess, to ask questions, to explore what good practice might look like, and to share that good practice too. And really importantly, Circle also had a co-designed resource. So one of the aims of Circle was to bring together community members, so LGBTQ community members with direct experience of social and residential care, and also people from residential care, so care workers and care managers, to come together as equal collaborators. Is that the right? Yeah, collaborators. Okay, get my teeth around that. Equal collaborators to design a resource which would be ideal for residential care providers, because there are some resources out there for LGBTQ inclusion in residential care, for example, or in social care more broadly, but they're often quite dense. And if you're a worker in a residential care setting, training time is limited, budgets are limited. So there was this idea that it's action-focused resource. You can find more about the Circle project at this website, and all of the slides from today will be shared with the audience as well. So, so the resource that was created was a Z card, which folds out. So it has lots of top tips about how to apply LGBTQ inclusion within residential care. And there's an accompanying animation as well. And so you can go to the website that's listed there. The project got lots of media attention. So this resource, when it came out last summer, yeah, time's flying by, generated a lot of media attention from the BBC, from more LGBTQ specific organisations and media outlets, and from organisations like Care Home Professional. And I guess the next slide will kind of tell us about the importance for me as a researcher, and I'm continually learning, the impact, I guess, of conducting research with LGBTQ communities and some of the outputs and where they go to, how they're used, how they're viewed. And so the next slide was, I guess, the counter to all that positive media attention that this resource created. Some of the media and newspapers picked up on the resource when it came out. And there was a direct quote from an organisation that was reported in one of the newspapers saying, "This guidance for care homes is a shocking example of the way trans activism harms the most vulnerable in society. By imposing the fictions of gender identity ideology on gender-confused older people, it goes against the best interests of residents and staff. Rather than offering practical, compassionate advice on how to provide care in these difficult situations, this guide treats vulnerable residents as props in a fantasy of gender affirmation." And so that's a wake up, I think, for me. You know, I can talk to my experience about the impact of my work, my research, when it involves LGBTQ plus communities, because that has an impact on me as a researcher, and also all of those people who gave their valuable time to participate in studies, to create with love and affection, I guess, resources that are much needed, I guess, in health and social care. Okay, part 5. So this final part just talks about my current PhD research. And I now have a project which is called Show and Tell, and I use an approach called photo voice to explore the experiences of LGBTQ plus people living with dementia. And photo voice is a research method in which participants, who are often referred to as participant co-researchers, they take photographs of things that are important to them to illustrate their personal situation. Their images are supported by their explanations, so they're photographs and stories on their terms. They form a visual record that can be used to tell stories about their lived experiences, engage others in dialogue and discussion about their communities, and reach service providers and policymakers to initiate change. So there's a social action for social justice kind of element to photo voice work. Photo voice, I guess, aims to establish more equitable relations within the research process. So shared decision making is core. It aligns with a sort of social citizenship approach that recognises that people with dementia should have equitable access to human, political and social rights. So in the summer, I conducted a pilot study with 5 LGBTQ plus people living with dementia who are part of an advisory group from my project. So they stay as advisory group members for the 3-year duration of my project. And they kindly agreed to become participant co-researchers with me to explore the use of photo voice. Photo voice has never been used with LGBTQ people living with dementia. So it's a novel use of this photographic method. And so we need to understand what's good about it, what works, what doesn't work. It was a small pilot study conducted over 4 weeks in the summer, and people took photographs along these suggested themes, which they suggested. So LGBTQ identity, sources of strength and support, living with dementia emotions and feelings, and my community, and people could deviate from any of those themes too. They used their own mobile phones as cameras, and there was also some online camera skill sessions throughout the project, this pilot study project. So we blended kind of learning with social activity with research. And people felt real value from participating in this photographic based project. So this talk of imagery conveying much more experience than words alone. People felt that the potential for photo voice would have this idea of leaving a lasting legacy for LGBTQ plus people living with dementia, a record that might live beyond them. A real validation of who they felt they were, and that the project gave agency. It meant that people could also learn new skills, connect with others. So this opportunity for kind of peer support as well, to share photographs and stories with others, was really, really valuable. And at the time of this study, it was the run up to the general election. And so, like I said in the earlier timeline slide, there was a lot of talk around, particularly around trans identity. And also there was a television campaign from Alzheimer Society, which came out at the same time, which was called The Long Goodbye, which referred to people with dementia as continually dying. And so people were really knocked by both of these sort of social and media messaging about who they were, who they are. And so they used their kind of photo taking opportunity, this photo voice pilot study, to take more ownership of their narrative and to kind of tell stories on their terms. And a little montage, I guess, of some of the photos that were taken, because people are often keen. And this very kind of resounding message: queer people with dementia have their own unique voices, so don't talk for us. And I particularly like the photograph at the top that says, lesbian grannies just say stop. So they were saying stop to the war in the Middle East. So now I'm at the stage, I'm recruiting for the next phase of my study, and I'll be broadening my study to make sure that I recruit people from the broadest social location of LGBTQ identity, so accounting for where they live, socioeconomic status, ethnicity, age, education status, for example, as well. So trying to bring in all of those factors to my research. And that's the next stage for my particular project. And I've written up the pilot study, and that study is out for review at the moment. So once it's published, I'll make sure to connect, I guess. I'll share all these slides and I'll connect with the team as well, so they have that information. Okay, so at the end here, just a few kind of resources to take away, which I quite like to signpost to. So LGBT Foundation have a terrific report called If We're Not Counted, We Don't Count, which is the importance of collecting sexual orientation and gender identity information in health and social care. Reports from Stonewall are often helpful, so health reports and are quite good to read. Carers UK have a Supporting LGBTQ+ Carers Good Practice briefing. And Skills for Care down in the bottom right there have the LGBTQ+ learning framework, which is a very comprehensive multi-module approach to LGBTQ+ inclusion, I guess, and tips for LGBTQ+ inclusion. And of course, Alzheimer Society have several kind of information pages on supporting LGBTQ+ people living with dementia and LGBTQ+ caregivers as well. And a couple of books, a recent book that was published, the LGBTQ+ People with Dementia Good Practice Guide, which is a really nice, very accessible book for all, I guess. And a really nice book called Challenging Assumptions Around Dementia. So led by people living with dementia, telling their stories. So that's me. And you can always drop me a line at j.hammond2@uni.bsms.ac.uk, and my number's there too.
Brilliant. Thanks ever so much, John. That was a really interesting and also an accessible presentation. Really great to hear, and some very good ideas, I think, about how things might be improved in practice that you gave. So we've already got about 3 questions in the Q&A, which is good.
Right.
But just to remind people, if you'd like to ask a question, please do just write your question or your thoughts down in the Q&A. Or if you want to speak and sort of come on camera, then you can raise your hand or just say that in the chat. So the first question was from Hilary Hammond. So Hilary says, with dementia, many can revert back to their childhood memories. I've been asked where a trans person would be best suited in a ward setting if they have reverted back to these childhood memories.
Yeah, I think it's a kind of resounding concern specific to, certain people within the LGBTQ+ spectrum. So trans and gender diverse people, and I don't have an easy answer, unfortunately. So what we do, I guess, in my work, we need to hear much more about the voices. We need to hear much more from the voices of those living with dementia who identify as trans or gender diverse. and we need to hear what their kind of expectations, I guess, of health and social care will be. We live in a all research, you know, like as I alluded to in the presentation, but we live in very changing political and social times, and attitudes towards trans people are less favourable than towards cisgender people with lesbian, gay and bisexual identities, for example. So I don't know what the answer is. I know we need to hear much more first-hand experiences from trans and gender diverse people, and we need to engage, I guess, with trans and gender diverse people on a kind of human level. That also accounts, I guess, for this changing, difficult social and political time. So I'm treading horribly on a nasty tightrope and not really giving an answer, but I do know that the more we hear those voices, and I guess that's central to my work in my research, the more I can talk to kind of good people like yourselves, and we can understand more about, I guess, expectations, what's needed, I guess, for health and social care for the future. Because more and more people, if we you know, follow a particular trajectory, it looks like more and more people in the future will identify as trans or gender diverse in some way. They may not identify on the binary of male and female, and so we are going to have to future-proof, I guess, our health and social care systems if we truly care about humanity for all of those who interact with them.
Brilliant, thank you. So there's a couple of questions from Sam Thomas. So I'll ask the first one to begin with. So Sam says, have you considered a best practice video for health and social care workers with hints, tips and voices of LGBTQ plus people living with dementia?
Yeah, good. That's a terrific question. And some of the outputs from my project. So at the moment, a slight tangent, Sam, I apologize, I'm going on a slight tangent, but I'll come back. So one of the outputs from my research at the moment is one of the participants who took part in the pilot study doing a video with me to talk about their experiences, and also the power of the photo voice experience for them, and encouraging more people onto the project. So in their words, on their terms. I'm sure good practice kind of videos might exist, I'm not sure, but there's always space for more. So I don't like to reinvent the wheel, so I'm not sure what's out there currently. I'd have to do a little bit of a thing, but sometimes, like in my project, because of the nature of this kind of participatory kind of really foregrounding the kind of experiences of the participants, the co-researchers, all kinds of unexpected things come out, like this video that's being created for the next stage of the project. So maybe we'll take that away and we'll do you know, a kind of a video part 2 where people can talk about their lived experiences, and maybe how they, you know, their top tips for you know, inclusion within social care. And I guess I'd signpost back to the Circle project as well, because although it's not a video, the resource is downloadable. So I should have said that on the Circle project, the Z-Card resource, which is on the web link, which is in the slide, you can go to that and you can download a digital version of the resource, and you can see the animation as well. So those resources were created by LGBTQ plus people with experience of social and residential care. So they're really valuable downloadable resources, not videos, but still good resources.
Good. Okay, there's a second question actually from Sam, but Sam, I'm just going to, if you don't mind, I'll just park that for a moment, because there's and take a question from somebody else, and maybe come back to that if we've got time. So this is from Morgan Brett. So they say, I recently heard a story from a carer. They have a trans woman in their care. Before her dementia had progressed too far, she told her carers that she would always like to be referred to as a woman and always like to use her female name. When her dementia progressed, she asked to be referred to by he, him pronouns and using her formal male name. The carers were in a dilemma, because respecting her wishes as a trans woman, but also mindful about the confusion which came with her dementia, they chose to respect her as a trans woman and continue to refer to her with her female identifiers. I've heard conflicting opinions about what would have been right in this situation. What would you have suggested?
Well, that's another $1 million question, isn't it? I think it's really difficult because we, of course, always want to respect. We always want to give respectful care, I guess, to those we interact with in care services, and we also need to appreciate that sexuality and gender identity, I guess, can be fluid as well. And so there is often not one way to have our experience as LGBTQ plus people, and that includes, there's no unique trans experience either. And so, yeah, it's a weighing up, I guess. Often, I guess, at a time when somebody's decision-making capabilities may be diminished in some way, if they had, and this is something I kind of advocate for and often suggest very strongly to people, is make your wishes advance, kind of like care directives and advance wishes known. Write those down, make those clear, because as Morgan says rightly, you know, people's situations change, their capacity to make their decisions may fluctuate, but those decisions made beforehand may be integral to their identity, maintaining that identity and receiving that respectful care that they would have wanted. So really encouraging people to make those advanced directives is really important. Just so that it also supports you know, health and social care workers to be I guess the most prepared they can be. But of course, not everybody makes those advanced decisions about their care. It's a tricky one. It's a really tricky, isn't it?
Yeah, no, it is. I mean, as it's quite a hard question, and I was thinking in a similar way. I mean, maybe it is about advanced care planning or lasting powers of attorney, and maybe then have to make a judgment about the person's capacity
Yeah,
to make that decision, you know, when you revisit it, because people have obviously got the right to change their minds if they want to, but then I guess it's, are they able to make that decision in a capacitated way or not, I suppose, would
of
be the
course.
key
And
thing.
all decision making is situation specific as well, isn't it? And timing,
Yeah.
and you know, thinking about all of those things. When did the person make the decision? Under what circumstances did they make that decision? Was it a time of day? Was it an influence from maybe other people in a residential care setting? So they're wanting to gender conform in some way because of other external pressures. So out of context, it's a really difficult question to answer, but it's an enduring question. You know, people now are asking a lot more questions about, specifically, I think, about health and social care to trans people, to trans older people, and to trans older people, for example, living with dementia as well. It's a very definite topic, and there are some, you know, specific pieces of research coming out which are specifically recruiting trans people with dementia, for example. So we will start to get more and more stories. We will start to get more and more of that, those needs, I guess, specific and unique needs out into the world. So at the moment, we're still exploring what that can look like as far as good, inclusive care, affirmative, celebratory care as well, I guess. So.
Sure. We've got about 3 minutes left, and there's one
Ooh, time
question.
is
So I'm going to
flying.
just
Okay.
put this to you as a quick question, and then I
Yeah.
think we'll, if you could give me a couple of minutes just to mention the other things which are going to be taking place as part of this series. So Sam had also raised another question, which is, as a social worker, we want to empower and support our users of care and support how they can protect their voices and their identity when dementia can strip that away. So would photos or videos help? And I
I
guess this
think
talks to your method, doesn't it?
yeah. And I think you know, I've been struck. I'm not an arts-based researcher, you know, by background. I've kind of you know, become this kind of passionate advocate for photography and imagery, and I think there's a real place for the use of images in photographs, for example, in interactions with health and social care workers. Because they are so evocative of different of memories, life stories. You know, they facilitate incredibly rich conversations, and so I would, if you are so inclined, I guess, drop me a line as always. But I think the power of photography and imagery is immense to build rapport and relationship as well with health and social care workers too. So.
Brilliant. Well, I'd just like to thank you, John, for your presentation and for answering those questions. It's been really interesting and engaging, and I'm sure the audiences have enjoyed it as much as me. So thanks for giving the time. And before we finish, I just want to remind people of a couple of things. So this is part of a series, an online conference series called Dementia Support in a Diverse World. So if you have missed any of the presentations and you'd like to see them, the recordings will be online, and that will also include John's presentation today if you want to suggest it to a friend in practice. And our last presentation, which is keeping well before, during and after a dementia diagnosis for people who have Down syndrome. Sophia Vugaglu from CARE and Julian Hallett from the Downs Association in Wales will be presenting on Monday at 12 till 1, and that's online if you'd like to join us. There's also a podcast with Professor Suzanne Carhill about dementia, human rights and social care if you'd like to listen, as well as some online resources as well. So thank you very much for attending, everybody. Thanks to John, and we hope to see you again at some point soon.